Welcome, Mahmoud. Tell us about yourself.
So my name is Mahmoud Elsayed, and I'm originally Egyptian. I came to the UK in 2014, and I'm currently doing a locum consultant post in Manchester University Hospitals. I'm married. I have three children, and I work in different hospitals in the UK. I went through the exams, and I did the CESR application and it was accepted. And I did also some thyroid, parathyroid fellowship in Reading. And I'm currently, hopefully, very soon will have a substantive post. It was quite a long journey in the UK from overseas to be on the specialist register, and I have gone through the CESR pathway twice, and that's why I think I have quite good information to help my colleagues and whoever is listening to this podcast to help them to get through the same pathway.
And what attracted you to UK?
Uh, the main point actually is the chance to have high grade surgical training. I was listening to previous podcasts. High quality training you can't find it in overseas in the majority of countries, especially in my area, unless you are working in a big university hospitals. So the vast majority of my ENT practice when I was overseas was actually doing very basic ENT surgery like adenotonsillectomies, cystoblasts. But if you'd like to actually increase your exposure, and it is very difficult to get someone to teach you this stuff. And so it just came to my mind if I could do some qualifications, do English test, I could secure a better chance of training in the UK. This was the main target. Other targets, something about family and living in developed country like the UK, better education for the family and for my children as well. And to be honest, part of the package is if you work in the UK for 5 6 years on a visa, you at one point you will have British citizenship, which is actually something for us. It's quite very important. It will be helpful for me for my children as well.
Mhm.
So this is where the three main targets actually to come to the UK.
Mhm. So, what is the CESR pathway?
So CESR is Certificate of Eligibility for Specialist Registration. This is how it defines. And simply it means you need to convince the General Medical Council that your experience, your qualification, the amount of work you did is equivalent to the CCT, the training that the normal UK trainee will have. So if you could offer enough evidence to the GMC, which actually will take this evidence and give it to the Royal College of Surgeons, if both of them are happy that the evidence you submitted is equivalent to what they ask their normal trainee to have, if you could get this criteria, you will be on the specialist register.
Yeah. Okay. And why might somebody go down the CESR pathway rather than enter training and get CCT via that route?
So this is a very good question, and the short answer is uh, it depends on the specialty. So CESR is not the best option. So the best option is actually through a normal training pathway. But the majority of the specialties, the competition rate is very challenging. So you can have like a competition 1 to 5, 1 in 10, 1 to 20. And also the competition is not in our benefit. Someone coming from overseas, you had lots of ENT experience, and then if you worked more than 3 years in ENT, for example, you will lose 20 points in your portfolio. Actually, say if I go to my SHO into a training program, she had already 20 points in her pocket, and I don't have these points because I had more experience in the ENT, which by some way is quite fair because I am older, I had the chance to work, she didn't have or he didn't have this chance. So the competition is very difficult, and for us to get high points in the interview is very difficult because if someone coming from overseas, Egypt or India or whatever, We don't do a lot of audit or publication or presentations, quality improvement project. This is not something very common they are doing overseas. And then if we go to interview, the balance will be shifted always toward the trainees, so you will get more points. And also, one of the things that is very challenging, to be honest, is the communication skills. So one of the main parts in the training interviews is communication station. So if your English is not very good, your communication is supreme, you wouldn't get lots of points. So if it is like out of 40, if I do my best, I will take 20, 15, and then someone originally British had been raised in this culture will easily get 35 points. And also the management scenarios usually are built on the system in the UK, not built on our system in Egypt. So the message is, it is very challenging to secure a training number if you are not raised in the system. So for example, for ENT, I only know one person who could secure a training number in ENT from Egypt for the last like 10, 15 years. So it is challenging. And that's why it is very important to actually try to go for CESR. If you couldn't get the training number, I think it was quite nice from the GMC and the Royal College to make another route to help people to progress in their career.
Okay, so it's about the fact that if you're an international graduate, you don't have the same portfolio, the same
Yes.
experiences, and that means that when it comes to applying, you're just you're just not competitive. And I guess also I wonder, it depends on the age at which people come, because sort of maybe if somebody comes to the UK, in their mid-30s, would they want to go back and be a core trainee when they're in their mid-30s? I'm guessing people wouldn't.
Yeah, I totally agree. I think if you go through the training from ST3 to ST8 and you are 34 years old, this means that it will take you 5 or 6 years to finish the training. But in theory, I think still, if there is any chance to get a training number, it is better, because finishing the CESR totally in the UK, in my opinion, it will take at least 5 years. So it will need lots of evidence. So just if we are discussing this for everyone, the top tip, one of the top tips is, if you could secure a training number in the specialty that you would like to go for, this is the best option. If not, you need to go for the CESR pathway.
And what makes the Caesar pathway more difficult?
Uh, so it is you need to, it is designed, as we mentioned in the first one, to be equivalent uh, to the normal training. And I said it is not difficult, it is challenging, and it is like a marathon. So you need to collect lots of evidence. If you imagine how much evidence a trainee will put into his CCT application when he finishes his training, it is a huge amount of evidence. You need to get evidence about the four main domains that we will get in more details in a minute, to convince the GMC and to convince the Royal College that you have the same amount of training. So you need lots of training, mandatory training, publication, CMEs, points, appraisal, assessment, communication, research, publication, presentations. So it is not difficult, but it needs to be very, very well organized. From day one you come to the UK, you should have a plan from day one. My target is not the exam, because the exam will take only one box in the about like 15 books of the CESR application. So when you come to the UK, this is again one of the top tips is, from day one you come to the UK, you need to know that I need to go for the CESR from today. I need to prepare my evidence, because I know some people, they did the most difficult step, which is passing the FRCS exam. And when they finish the exam, they said, oh, I need to collect evidence for CESAR. So to try to collect this evidence, this will take you like 3, 4 years. And that's why it is a lengthy, exhausting process, but it is not difficult if you know what you really need to do and prepare well for the requirements.
Yeah. So it's if somebody does 2 years of core training and then 6 years of specialty training, it's going to take them 8 years. And likewise, you might have an advantage in terms of operative skills if you're going down the CESR route, but you still have to collect 8 years worth of evidence. You might be able
Yes,
to do a bit quicker, but it's basically 8 years worth of evidence that you need to showcase and find.
yes,
Yeah. Okay. And you mentioned there are 4 domains. So what are the domains?
yes. So, uh, one of the top tips again, when you when you decide that you are going to do Caesar application, you need to create a folder in your iCloud or Drive, Google Drive, into 4 main folders. And in these folders, from day one, you need to throw your evidence in these folders regularly. So by the time you say, I'm going for the Caesar application, you have all your evidence. So the four main domains will be knowledge, and then safety and equality, and then communication, partnership, and teamwork, and maintaining trust. And the first domain, which is actually like 80% of the evidence, has like one, two, three, four, seven subcategories. The first one is your CV, which should be designed according to GMC guidelines. It should be showing lots of stuff in it, and because this actually like a portfolio for the person who is assessing your CV. And folder two will be qualification. What are your qualification? FRCS exam is the minimum requirement and the only requirement you really need. So if you have FRCS or LHS in exam, this will tick this box. You don't need to put any other stuff. If you put other stuff, like if you have a master degree or PhD or DOHNS or MRCSNT, this is a bonus. But the minimum that if you don't have it, it is too difficult to tick this box is FRCS exam. And that's why it is crucial part of the application. And the third part will be assessment and appraisal. Assessment is quite big because this actually the majority of the evidence will become from each year assessment, which like work-based assessment, which will be case-based discussion, procedure-based assessment, clinical examination in the clinic, consenting patient. And so it is like something you are doing every day in the clinic with your consultant in the clinic, and also on calls, and also in theaters. And you should update this regularly. So I think trainees should collect like 40. You can correct me because you have been a training program director before. You need like I think like 40 work-based assessment per year. I think this is what are you expected to offer to the GMC as well if you are applying for the CESR. So assessment, work-based assessment, and appraisal. So for people who are not trainees, we don't have ARCB. We have something called the appraisal. And in the appraisal, it is quite similar to the ARCB. Again, you are showing in the appraisal what have you done through this year, your job plan, your theater sessions, your clinical activities, your on calls. Did you do an audit? Did you do any incidents? Did you have any complaints? Did you do your mandatory training? So it is very important. A third top tip, you need to keep record of your appraisal because you'll be asked to put a copy of your appraisal in your CESR application. So you need to keep this in the folder. So after 5 years, when you try to submit your application, you don't keep phoning people in a trust that you worked 5 years ago. Can I have my appraisal? This is just from day one. You need to prepare everything, and you need to have a logbook. And logbook, it varies from specialty to specialty. So I will try to make this podcast quite general, not only for ENT. So for logbook for ENT, for example, you need to keep a logbook for your surgical procedures. You should have a minimum number of, for example, 2,000 procedures, and it should be covering all the domains of ENT generally in general. You should have something called the emergency logbook, showing that you did ward round, you did emergency clinics. And the logbook, according to the GMC, you need to divide it by year, and then you should have detailed logbook, and then another logbook showing. So all this stuff will be communicated to you when you submit your application. So the logbook is very important because it reflects the surgical exposure that you had over the 5 or 3 4 years that you did before submitting your application. And fifth folder will be your posts, how many jobs you have done in the UK. So for example, you did a SHO job, what you have been doing, what are the rotas, and then you should have your job description. So if you do any job, always keep copy of the job application because it will have what are the duties of the job. And you should have a letter from the hospital mentioning that Mahmoud worked in this job and his job was this, was doing this, and this is his rota. And you need to keep also a logbook of your like on calls because one of the requirements is that you should be covering a certain number of nights as on call. This is for ENT. So post contracts, you should have your contracts as well because usually they know that you have been working regularly over the last like 4 or 5 years. Sixth folder will be research. You should be doing some mandatory research courses like good clinical practice, critical appraisal. Some of these courses are mandatory. You must have them, and you should have. You should be very, very well aware about the publication requirements for your CESR. It's very important because actually this is why I failed my first trial in my CESR application. So you should understand exactly what is really needed. For example, for ENT, you should have at least 2 publications in peer-reviewed journal, and they shouldn't be a case report. So invited publications, although you may be doing lots of effort, have like 5 professors in it, it doesn't count because it is not peer reviewed. Case report, whatever it is not counted because it is a single case. So you should know exactly what you need and what is needed in the criteria. And to be honest, there are 2 things that will make things very, very difficult in the CESR application. First one is the exam, FRCS exam. Second bit is research. And the reason research is very challenging, you can't sort it within 1 day or 1 month or even 6 months. It is very difficult to find a topic and convince a journal to publish it and get it approved and be online. That's why you need to start preparing your research from day one because if you decide to start publication process, it take 1.5 years. So you need to start early. And then you need to have evidence of your CBD, your certificate. Usually each specialty will have mandatory courses that you must cover to be successful in the CESR application. For example, again, for ENT, you should have a FIS course, temporal bone dissection course, laser course, head and neck course, facial plastic course, and you should have ATLS plus minus EBLS. And these courses, if you don't attend them, your application will fail. And the top tip again, another top tip is the person looking into the application, usually you must have everything as it is mentioned in the criteria. You can't have one thing missing because if it is missing, your application will fail. There is no way it will succeed. Some people told me if you put like 3 publications and they need 2, they actually can accept the 3 as long as they are 3, not 2, but they are not the best. But actually, they said no. Everything should be as requested. This is one of the things that should be cautious. Teaching and training, you must have a course called Train the Trainer or Midwise course. It is better if you could have a broad teaching experience. For me, I had a teaching fellow job for 1 year, which helped me a lot to take this box. So this is domain 1, which is 85% of the evidence. Domain 2 will be audit, and you should have audit and quality improvement projects. And I think one of the top tips is you must do the same number trainees ask it to do. So if I apply for CESR application after 4 years and I bought 4 audits only, there is a chance that they will say we need 7 audits or 8 audits because this is actually what the trainee will submit. So it is always better to put at least 7 or 8 audits in the application. One of the things that is is better if you could have them is something called self-assessment audit. You need to do an audit assessing your experience. For example, doing tonsillectomies, how many cases did bleed, or doing endoscopic sinus surgery, or doing rhinoplasty. You should make like self-assessment of your performance and ask one of the senior colleagues to assess it. And you should have a full cycle audit. So you make an audit, and you detect that there's something need to be changed. You implement the changes, and then you do another full cycle or another cycle. So it should be like a full cycle audit rather than having a one cycle audit. Quality improvement project is quite will count as an audit. Or if you're writing a guidelines in your workplace, it will be counted as like some quality improvement project. Health and safety and communication partnership. Just like this will be quite general for something actually about your life, what you have been doing outside the ENT career. Have you been involved in our extracurricular activities? You should have like communication. Communication means that you have any compliment letters from your colleagues or from patients, and also you will have submit any complaints. Did you attend any communication courses? And reflection sometimes about difficult things happen for you during your training. Attending mandatory training. So this will be generally the core stuff of that you really need to fill. So to cap, the reason I have gone through all this like 10 minutes continuous talk is to tell you that it is a marathon. You need to prepare your evidence from day one. You can never collect the evidence once you finish your exam. So I'm now expecting a question now from you is how did you collect this evidence?
I'm going to come on to that in a second, but actually, the first thing I'm going to say is how do you find out what you need to do?
Yes. So how do you find? So you find this from there is something blueprint from the GMC and the Royal College of Surgeons, or there is, I think, GCST for otolaryngology. They will be setting up criteria. And for me, the criteria for me was exactly the same criteria required from the trainees. So you have 2,000 operation. You should have some named procedures that you should be doing at level 4 or level 3 or level 2. And usually one of the things that will happen in the process of the submission, you will be allocated to GMC advisor, someone. He is not ENT, I don't think even he is medical, but his job is to make sure that your application is meeting the minimum requirement before sending your application to the Royal College. And you know this also, this is one of the top tips again, from people actually who did the CESR before you. So many people will call me and ask me what we need to do, Mahmoud. And I did the same. I asked people, and then I will give them my top tips. Be careful from this. You need to collect this evidence. So it is like learning from mistakes, actually, because sometimes you don't find everything in the publication, but in the process, you will be supported very well by the GMC. One of the good things that you should put in your mind is everyone is trying to help you, especially the person from the GMC, the advisor, is actually trying to make your application as successful as possible. If he asks you to do something, you should never challenge him. You should take it with love and respect and try to do it exactly because he is working on your side, not against you.
Mhm. Yeah. One of the things that I'm hearing is that there's lots to collect, but it is the equivalent of 6 years or 8 years worth of training.
Yeah.
And it's what you're saying loud and clear. It's not something that you amass together in 2 or 3 weeks or even 2 or 3 months. It's going to take it takes many years of training, and it's going to take you a number of years to amass all of that. So how can you get all of that evidence?
Yeah. So if you are lucky, you will see someone that will tell you there is something called e-logbook, which is actually electronic logbook offered by Royal College of Surgeons of Edinburgh. And then you can actually, from day one, any surgical procedure you assist or you perform, you will add it on this logbook. So by the end of the 5 years, if you go to your logbook, you find that like, there is like 2,000 operation already waiting for you. The second thing is using the ISCB website, which is usually used by trainees to document their activities, but actually it is open for non-trainees. And I strongly recommend that if you are ENT or surgery, you should use this website, even if you have to pay money for it. It's like £250 per year, but this money is nothing, because at the end, once you have your evidence, you will say, it deserves all the money I paid for it. This website, you can actually, you can submit your work-based assessment, and you can send them to your consultant to sign them off. And so it is very helpful to have this website from day one. This site from day one, because after 2 years, you go to the website and will say, download my evidence, and it will be creating for you 2,000, 3,000 pages of evidence. So your application, it will be appealing, it will be nice. And it is electronic, you don't need to sign anything from anyone. So it is crucial from day one to collect your evidence through elogbook.com, RCSED, and ISCB website. And you should also keep emergency logbook. There is, in ENT, there is a special Excel file for it. I'm not sure about other specialty, but generally, if you are internal medicine, they have something called a portfolio that you need to use it from day one. And if you are ophthalmology, you can have another application. Whatever your specialty, you need to ask the trainees, what is the thing that you are using to document your evidence, and you need to use it if it is available for you as non-trainee. If not, there should be something that you must use, because it is essential to help you through the journey of the CESR.
And how do you make sure that you get the same kind of learning opportunities that trainees get in order to demonstrate all of these competencies?
Yeah, so this is quite critical. And the answer of this question, I think it will be philosophical rather than practical. So when I came to the UK in 2014, my first job was in King's Lynn, somewhere near Cambridge, Norwich. And I met a Sudanese orthopedic consultant, who was actually a substantive consultant. I told you, how did you get a substantive consultant? Everyone is telling me it is impossible to have a training number or be a consultant in the UK if you don't have a training number. And he said to me, oh, so how did I become a consultant? So actually, he told me there is nothing impossible as long as you are trying to do it. So you cannot control people or environment outside yourself. You can only control yourself. So if you keep trying, you will find opportunity. I started a job as a SHO in Kingsmill Hospital, and then I went to a specialty doctor job in Wales for 2.5 years, and then I did a teaching fellow job in Derby for 1 year, and then after all of this, I had my golden opportunity coming for me to do a registrar job in Queen's Medical Center in Nottingham, which was actually changing for me. So if you keep trying and keep updating yourself, you will find a chance that will come to you at one point. And I believe the people generally, like consultant or senior, will be always supportive for active people if they actually feel that you are trying to progress and to improve. They will support you. I think this is part of the culture I did find wherever I'm working. So in any place, people will try to help you, but they really need to make sure that they feel that you are hard worker, you do your best, and if you do this, you will be paid back by time. And so this is what happened for me. But the philosophy is, if you start a job, So you will need to help me to rephrase this if people didn't get it. If you start a job in the UK as a middle grade or trust doctors, you have two options. Option one, to be a trust doctor all your life, or to try to progress to be a consultant. The good news is both pathways, they are not against each other. You're actually, if you keep doing a middle grade job, but put in your mind that I would like to progress, start collecting your evidence, start to getting all the boxes ticked in timely manner. At one point, even after 4, 5, 6 years, you will have the evidence. So you just need to keep trying. If you need to change the job to fulfill certain criteria, that's fine. You can do it. But it is something that you need also to consider. What is the most important bit for me? Someone just came like 32, 34 years old, and his children are young. So it is easy for him to move from one city to another bigger hospital or do a fellowship there or there to get more evidence. Someone 45, 46, it may be difficult with children in GCC. He will have to settle in one big hospital and the flexibility to move will be challenging. But the message is if you keep knocking the door, someone will open. This actually is the core message of how to make progress.
Does it matter what kind of a hospital you work in?
Yes, it does matter a lot in two bits of the application. The first one is the exam, because getting into the exam and passing FRCS exam, I'm speaking about ENT, is very, very challenging, especially for overseas. So I know that failure rate in part two, and this actually found on the GCHT website, the failure rate for overseas doctor for part two in the first trial, maybe like 80% or even more, because the exam is challenging and it is built on the culture, and also it is actually evaluating trainees who actually rotated in four big hospitals. One of them is a tertiary referral center. So if you didn't get a job in a tertiary referral center, the chances that you will get your exam, I will say very, very low. I know lots of people failed the exam like 3 times, and you have only 4 trials. And if you work in a big center, and I will take this opportunity to make some advert for Nottingham University Hospitals, if you work for a big hospital like Queen's Medical Center in Nottingham, because you can see everything. You can see pediatric, you can see advanced head and neck surgery, you can see cochlear implant, and you're doing like emergency cover for a huge area with brain abscess, frontal abscess. The chances that you will pass is very high. So myself and another registrar from Queen's Medical Center could pass this exam from the first trial. I think this two of the three people passed the exam from the first trial all over the UK. So you must have a job in a big center doing everything, because the examiner in the exam is expecting that you have gone through the same amount of training. If you work in a DGH hospital and someone discusses with you how are you going to do a supraglottoplasty and how you manage a patient total range of pharyngectomy, and you have never seen it, so you will be exposed and the chances that you'll pass will be very low. So big hospital, unfortunately, is a must, and it is not easy to secure a job there, but you need to build up your communication, start in a small job, attend MDTs, try actually to do ordinary contract, so you get your feet in a place, attend some sessions, people will know you, and then hopefully if there is a job, they will offer you a job. So again, keep trying, and as long as you are trying, help will come at one point.
What's been the most challenging aspect of the CESR application for you?
The most challenging is getting the right training. So it wasn't easy journey for me from 2014 until 2017, like 3.5 years. I had been moving from a very small hospital to a small hospital to a teaching hospital. And the system, unfortunately, so it is fair to mention all the pros and cons, is not designed to support the trust doctors, because they are trust doctors. They are supposed to do a job. They are not supposed to be trained, and especially in big hospitals. And it is fact that we should accept, because we didn't come to the UK mainly to get consultant job or progress our careers. It is a bonus. It is something that you can do in your own time and on your effort. So the most challenging bit is the equal opportunity in the training, which is difficult in big hospitals. But if you are working in a DGH, usually you have no trainees, and then you have a very good chance that you are working with a consultant one-to-one in theaters, and then you can tick the boxes for the majority of basic surgery like adenotonsillectomies, fist, septoplasties, rhinoplasties. But getting to the fine-tuning, the difficult, challenging ones, you will have to move to a bigger hospital. And then the design of the route in bigger hospital is offering certain minimum number of theater sessions to the trainees, and that's why the remaining vacant theater sessions will be very limited. And this is actually decreasing the amount of theater exposure, but the quality is very high. So actually, it is still something that you need to try. And I think if you have the wisdom and the policy, you can still manage, because I did work with two of my consultant colleagues before, and I always mention that there is always some way that you communicate and negotiate with people to get the maximum chance of training. So you can actually, if you are doing, for example, like tympanomastoidectomy, you can actually choose part of the surgery that you can do that you really need, and leave the other bit that is more advanced for the senior colleague to do. So both of you are happy, and you did get what you needed. So you should have very good negotiation skills. Show respect to people so they can support you. Don't be challenging. And to be honest, sometimes this support can come from the consultant leading the theater sessions. He can actually, I have seen this in Derby, I have seen this in Nottingham. In the morning, the consultant will see the team that he had in theater, and he would say, what do you want from this list? And what do you want from this list? How can we make things work for both of you? And this did work very well for me. But the you have to work hard. You have to move between hospitals, and you need to accept that you need to, for example, if one of the trainees is on holiday or doing a study day or doing exams, this is your opportunity. You need to be always aware about what is on the list. Is there someone there? Can I just jump to the list and I'd like to learn something? Can I be signed off something? So you need to work hard, especially in big centers, because it deserves, because big centers, they don't only give you theater exposure, they give you case-based discussion, they give you emergency exposure that you will never see in small hospitals. I have seen some myself. I had some scenarios in the exam that happened literally for me in my workplace. If I didn't work in a big center, I will never be able to answer this question. So it is not easy, it is challenging, but you have to try hard and do your best. And at the end, the philosophy is you are not going to lose anything, because your career as a middle grade is already guaranteed. It is going on. If you would like to upgrade yourself, you have to work harder.
And just my final question, your top tips. I know as we've gone along, you've mentioned some top tips, but just to summarize, what would be your top tips for a doctor who's contemplating the CESR route?
Yes, top tip number one, start collecting your evidence from day one. Top tip two, speak to registrars to know what are the requirements, and you need to tick all the boxes literally, exactly as required. Top three, try to find someone who did the CESR application so they can help and guide you. And there is only one thing that I need to mention, because there is a change that will happen in the CESR application, which should take over from 30th November 2023. I think they are going to change a little bit of the stuff. My feeling is they are making things easier for non-trainees. I don't think they're making things more complex because my era, for example, I didn't need to sign and stamp every paper. I need one person from the hospital to sign all my evidence from the hospital. I think what they're trying to make the documentation and the type of evidence should be more relaxed, which I think it is a better opportunity for doctors going for the CESR to work on it. It is not issued yet, but they mentioned that we will publish the guidance for each specialty. And in chapter 6, you will find that what are the changes. You need also to double check with GCST or to find if there is any change, and you need to tick all the boxes, literally all of them.
That's wonderful. Thank you very much, Mahmoud.